And go.
Welcome.
Hello.
How are you?
Yeah, good, cheers. Thank you.
Good. How's your morning been?
Yeah, good.
Any
Thank you very much.
placements?
Yep, a few. Think, yes.
You had to think.
I did have to think, yeah.
It's worrying.
Yeah, sinus lifts. There's a difference between sinus lift and sinus tap.
Such as?
If they've got insufficient bone to get stability on an implant, we might need to do something called a lateral sinus lift. We have to make a little window in the side of the jaw, and then the membrane is like a little bit like a balloon, and we just have to gently push that back, hopefully without tearing it or perforating it.
Okay.
And then we pack the bone in, and that puts back the bone that's been lost, which happens when teeth have been lost. The balloon kind of expands. Or sometimes it's naturally quite large anyway, even when you've got teeth. So the tooth comes out, and then you're left with this space. And to be able to put the implant in, you need bone. So we have to do this procedure called a sinus lift, or sinus augmentation. And then we leave that for getting heckled by stairs and creaks.
Loud mice.
Yeah, for a minimum of 4 months. And then over that time, the patient's bone has kind of integrated into that. And then we're able to hopefully put the implants in. So you make this little window, push that back, pack the bone in, whatever bone you might be using. So there's various thoughts on what type of bone: patient's own bone, combination of animal derived and the patient's own bone, synthetic, a combination of synthetic and the patient's own bone. So there's various degrees of evidence on what's the best type and which produces the best results. I think certain clinicians prefer synthetic, other clinicians prefer what we call xenogenic or animal derived, other clinicians prefer a combination of the two. I think there's certainly some merit in being able to use some of the patient's own bone. It's got that, what we call that osteogenic potential, putting some cells in there that have the ability to lay down bone already. So it kind of gives it, in theory, a better chance. Yeah, no, usually pretty successful.
So for those patients that don't have a lot of bone and have previously been told that they can't have implants, that's not always the case. That would be the skill set of the implantologist. Can everybody do?
I know why you're asking me that question. And that's because we've been asked that question. We've been told that's been the case. Can every clinician do it? Could they do it? In my opinion, yes, if they're trained. Should they do it? Not if they haven't been trained. But I think what's happened with some of those patients, and there's been quite a few over the years that have been told that they can't have implants, it's because maybe the person that told them that didn't understand what the solutions were. It might have been beyond their skill set. They might not have understood the procedures that were available for the patient. So I'm not trying to reflect. I don't know what was said in that surgical environment. You don't know what exact conversation has been had. So you can't judge. All we can say is, look, actually, there is a solution. This could work. And then you kind of explain the pros and the cons, because it's not all just fantastic. It's not magic. It doesn't always work. There are risks involved. You can irritate the sinus. You can tear the membrane. The patient's been through the procedure and it's not going to succeed. You're putting implants into a grafted area, and that's a lot of graft and very little native bone. So the risk of failure has increased. All the success rates are really high with integration. We're looking at about 98% success rate of implants integrating. But I look at the research, that's certainly reduced in sinus lifts and block grafts and things like that. Not a huge amount, but it's adding a procedure, adding complexity to the whole. We're talking about lateral lifts there. I mean, there's what we call internal lifts, which used to be called a sinus tap, because effectively what we used to do is we used to use, to put it crudely, a hammer and a mallet slightly short of the sinus membrane, and then use this technique where we used to hammer the bone up into the sinus and basically break the bone, push the balloon back, and then place the implant in that way. So you don't know whether the sinus has remained intact. There's ways of guessing, and then put the implant in at the same time, because you've got enough bone to get stability on the implant. So you can do a simultaneous procedure. A simultaneous procedure is where you can lift the sinus and place the implant at the same time. And it's all about that stability. But we don't use the tap anymore, of the osteotomes. We tend to use a much gentler system, which is you could call it a hydraulic system.
Yeah.
So we drill up with safe cutting drills, so they don't drill up to the membrane, but they don't perforate the membrane. So they will drill through bone, but they won't drill where you can still drill through the membrane, but you're a little bit more delicate. You have stoppers, so you've measured it on your CBCT scan, which you do for both procedures anyway, so you know how far away that sinus is, so they prevent the drill from going any further than that. And then you can share a little device and use sterile saline, effectively use a little syringe just to pump that saline in nice and gently and push that membrane layer to your implant. Now, I personally don't put bone in there because it's a blind procedure, because unlike the lateral lift, you can't see the membrane. You can draw back on the saline and you can then get an idea of whether you've got a perforation or not, because if you put reverse pressure on it, you're drawing the saline back out again. If you see air bubbles coming out of the little tube that you're using, and then you might think, well, there's a perforation there because that's drawing air out of the sinus. Not 100% correct, because that might not happen, but it might give you an indication that you've got a perforation. But it's a blind procedure anyway, and even then, if the perforation is tiny, you might not get air bubbles coming through. So for me, when I'm doing that kind of procedure, I don't put any product into an internal lift, but I know that certain clinicians do. And again, they use various products such as the animal-derived synthetic bone.
So with either procedure, be it the lateral or the other one, what can a patient expect to feel after? Would they feel any discomfort in the sinus area, or?
Yeah, I mean, you're going to feel something. Something's been done, so you can usually manage it with analgesics, ibuprofen. So it's going to feel a little bit tender. Tend not to recommend that they go scuba diving or flying.
Is that because of the pressure?
Yeah. You don't want to be messing around with it. And, implant designs. So you're putting an implant that kind of widens rather than a parallel implant in there, because there's going to be a change in the bone, in the stability. So if you're putting implants into it, we're talking about an internal lift, and you're on the minimum amount of bone, say for some people that's 3 millimeters. For me, I'm a little bit more conservative. I like to have 4 millimeters or more. And then you're putting that implant in, and if you've used something with parallel sides and that hasn't got a great deal of stability when you've placed it, or it still may have some stability, again, as that bone heals, the bone kind of moves away from the implant to start with, and then after a few weeks starts to move back again. So you lose that initial primary stability, we call it. You lose that initial stability, and after a couple of weeks, the implant is probably a little bit more fragile than it was when you first started. You get this little dip in stability. And if you had some real force, if they bit on something very strong, there's a potential, not always, but there's a potential to push that implant through and into the sinus. I'm talking about a real rare occurrence, but there's reports of it happening.
So if it did then,
Yeah.
I mean, if that was to happen, because it can, what could be done?
You have to get it out.
Okay.
Or you could leave it.
Okay.
But I don't think that's a sensible thing to do, because you're putting a foreign object into the sinus,
Yep.
and that's sort of floating around. It can migrate and cause all sorts of issues. You're usually then, in that case, if you can't see it through the, if it's been pushed right into the sinus, then you're going to do a surgical procedure where you do your lateral window. So you take, for instance, a CBCT scan, have a little look, try and keep the patient positioned into the same position, so you're not necessarily lying them back, because it can move around.
Yep.
Or be aware that if you are lying them back, that when you take your CBCT, as they're upright, as they move their head back, that implant can move from where it is. So when you take your CBCT, be aware. It gives you an idea. If you have to go and fish one out, hopefully that'll never happen, because you avoid it by using tapered implants or implants that are parallel with an abutment already on them.
Yep.
Should avoid that.
Okay. So there's a longer period of healing, right, between a lateral sinus lift and an internal one?
Yeah. A few weeks. It's not huge. I mean, you could be conservative again and you could do an internal lift. But let's say, for instance, you're doing a lift and you've got 7 millimeters of bone and you're only lifting by 1 millimeter or 2 millimeters. Then you have a much more stable implant. So you might be looking, if you feel that there's a need, you might be looking at 6 weeks or 8 weeks. And then there's lots of factors that come into this. It's not as straightforward as that. So you might find that the bone is a little softer, so you might want to leave it for a little bit longer,
Sure.
even though you've done. Usually towards the back of the mouth, the bone gets a little less dense as we go further away from the front to the back. So, you might want leave your implants a little bit longer. But I think that's a decision down to the clinician. And
so it depends.
And depends on what type of bone you have, the stability that you put in the bone in. And you get a kind of experience, it comes down to. You're getting a feeling as when you're drilling that bone, how the bone feels as you're drilling through it, what the implant stability is like. So there's various factors that change that timing, but there is a minimum time. So you certainly wouldn't be going in at 4 weeks or 5 weeks. I think 6 weeks is the minimum. But again, I'm a bit conservative like that. I'm not in a rush. Patients, better off waiting to get that long-term result. So minimum I'd be looking at an internal lift would be sort of 10 weeks, I would have thought.
Okay.
It's very rare that I'll go any earlier than that.
Okay. Well, we jumped into sinus lifts and sinus taps, didn't we? That was all from this morning.
Yeah.
So I know this week you've also got an IFL case, so a day case, all on 4, loads and loads of names for it. Talk us through just a brief summary of what a patient can expect.
What, as in when they're coming in for the surgery?
Yeah, for the day of surgery.
The day? Well, lots of pampering. So
That's the implantologist,
yeah. Yeah. Well, I think it's for a lot of people, it's a big day. It's a big step. They've probably not slept very well, very anxious, because they're coming to the point where they're losing all their teeth. and they've probably got to this stage for various reasons, but we tend to see people in this situation have a fear of dental treatment, and that's why they've got to it. It's not, it's unfair to say it's neglect. They haven't chosen to end up like this. It's not a choice. And for those that you could say that you've potentially neglected it, these are the next stages. We go through a robust process where we kind of educate them and help them and bring them to a stage where we feel that they are suitable for the treatment. So they've been through that process, they understand. But effectively what's going to be happening is the teeth are going to come out. And it's going to be all the teeth or the main teeth, usually, unless we're leaving some strategic sort of posterior teeth.
It's quite emotional, hasn't it, with some of the patients? I totally get it, because they are losing their own teeth, or the remaining upper or lower teeth.
It's a big thing for them.
Yeah.
Some people just breeze it.
Yeah.
And they're absolutely fine, get on with it. But the majority, I would say, there's a very big emotional step for them, and you can almost sense it. You need that empathy. You need to tune into that so that you can sort of, be aware of what they're going through. It's not the GA, they're not asleep. They're there, they're with you. And, you need a good team that understands that, which we've been lucky enough to have. And I think that everybody has, pretty much, if you're doing this kind of procedure. So what to expect? Well, it can be a bit intimidating because you're walking into a room where everybody's gowned up. Well, not everybody, but most people are gowned up. You've got a few people in there, so it's not just 2 people. There's a team of people involved, because we've got the way that we do it. We've got a technician, superb. So he'll be sort of constructing the bridge. So that can be a little bit intimidating. Then there's lots of anaesthetic. So, that bit probably isn't the nicest feeling. You're very numb, but we don't want you to feel any discomfort during the process. Lots and lots of anaesthetic. And then taking the teeth out, which can be various. Sometimes it can be quite a challenge because the teeth might be broken down.
Teeth.
Yeah. So they're not always periodontally involved. Sometimes they're just unrestorable and there isn't any other solution. So we're taking roots out, and that can involve, well, we want to keep the bone, so it can involve a lot of time. It's a delicate process, and that can actually take longer than putting the implants in sometimes. And then, without going into graphic detail, we need to move the gum out of the way so we can see the bone, place the implants. There's a lot of talking. We use a stent guide to guide where the implants are going to go. I tend to use more of an open stent, just in case I need to move the implants. But there are people that will use sort of fully guided, a different type of procedure. Same result. And then we put the implants in. That might be 4, might be 6, depending on what we're doing. And then, we'll be chatting away with Danny, so we'll be out liaising and kind of making sure that everything is ideally restorable. I don't mean ideally restorable. I mean in the ideal position for him to be able to do the bridge, because we can change the angle very slightly and give them a bit more freeway, if you like. Screw holes are going to emerge because these bridges are fixed on there. So there's a lot of sort of chatting and discussion about what's happening. And then, that might take a couple of hours, and then we'll start to sort of suture up. And then once we've done that, Danny would have had it's an impression as such, but the mold for the bridge with the cylinders on. And then he would have pre-made the bridge to a degree. And then he'll disappear off, wave his magic wand, and then he'll bring the bridge back, which will then secure onto the implants.
So they really do come in with their poorly dentition, teeth out, implants in, and go away with a functioning bridge.
A functioning bridge, we call it a functioning bridge. It's a provisional, and the reason it's a provisional is because the tissues have to heal. We don't know the exact position those implants are going to be in. We need something just to tide that time over, give the patient a little bit of time for everything to settle. So there are some changes. There's some bone changes, soft tissue changes that are going to happen over the next few months. We need to assess phonetics, the food, the ability to chew, and make any changes, aesthetic changes. And that gives us that option to make those changes and readapt before we get to the final bridge. But that's it on that day.
It's a big day.
It's a big day.
We've summed it up quite quickly. There's a lot of planning that goes into behind the scenes.
I don't want to make it sound like it's a breeze, because a lot of the work is in the selection and the planning and making sure it's the right thing for the patient.
And exactly what you've just said as well, selection. It isn't just that this is suitable for everybody.
No.
You have to, I say you, but there has to be a certain criteria when you're considering a patient for this kind of work.
Yeah, this is a last resort. Yeah. This is the end, really. There's no other option, because I think that dentures, if you can tolerate dentures, have dentures. Yeah. This is like the end of all the options we are. If we can put a couple of implants in and say, if you can save a tooth, save a tooth. Yeah. There's nothing better than your own teeth. It doesn't matter what people say about implants, what people feel about implants, they are a substitution for your natural dentition. So, you know, if a tooth has a good prognosis or even a questionable prognosis, but it has some more time, then usually we'll try and, you know, manage that. Doesn't mean we're nursing it along.
No.
And we do understand there are certain wants and needs for the patients. But as a clinician, you've got to guide your patient to the correct path for them. So yeah, we don't take on all cases with a selection. We'll try to be. We've got strict criteria that patients kind of have to fit into. And it's a lot for them to take on board and understand, and a lot for us to go through.
As you say, it's key having a good team behind you, though, to make it run smooth on the day.
Yeah.
As I said, there is a lot of planning that goes on in the background that
couldn't
doing.
couldn't be done without a lot of teamwork.
Yeah.
A lot of people involved in this. So it's not just down to the person that's putting the implants in. It's everybody that's involved all the way through the process from start to finish. But you know, I mean, it is. You know, we've got straightforward, advanced, and complex when we come to categorise the implants. And I think it was Colin that sort of phrased it. This is complex, and I totally agree. You know, this is the really complex stuff.
Yeah.
You know, and people talk about other types of implants, and when they're doing this procedure, they might talk about zygomatics and pterygoids. It's not something that I do. And I think if people are looking for that, then a solution for them, then I would be sending them down to somebody that does that full time or has a lot more experience than I would. It's not something that I offer personally, but I'm aware of it, and it might be a solution for the patient.
Yes. As you say, there's certain centres and places that do offer that option, don't they?
There's some very good clinicians that do it, and they do it all the time.
Yeah.
And
daily.
You know, those are the people that, if you're going to have those kind of procedures done, that you want to see. You don't want to see somebody that kind of dabbles.
That's fair enough.
But yeah, anyway, I'm digressing.
Well, I think we'll probably get heckled a bit more in a minute, because I'd imagine they're going to be finishing off their lunch.
Well, thanks for listening.
Well, thank you.